Hi, good morning, everybody. Thank you for giving us a minute. We are very pleased today on this very special Friday because it will be World AIDS Day on Sunday. And so we're already celebrating it here at Cecilia Makiwane Hospital. And for our special World AIDS Day presentation, we have Dr. Kayembe, who will be presenting today for us on adverse reactions, specifically caused by anti-tuberculosis drugs. And I'm also very pleased to announce here that last night, Dr. Kayembe received a Service Excellence Award here at Cecilia Makiwane Hospital for his extraordinary act, self-sacrifice, and exceeding expectations. So we're very pleased and honored to have him here doing this presentation for us. And I'm now going to hand over to him.
Is it working? Is the slide working?
Go to the slide, please. I'm sorry, if it does that, then just press on the screen and then we'll be at
It will be useless.
So just tell people to.
Can we try? Can we scan the active response code and see if it will be working, so that as we go, we'll keep it as interactive as possible. Is it working? Are you connecting? Okay, good. So we all know that TB is the leading cause, or is the leading infectious disease in the world, but not only in the world, as by the South African numbers there, it is also the top disease, the top killer in South Africa. So, and adverse reaction to TB, this is based on the data from South Africa earlier, is that adverse drug reaction related to TB cause death in hospitalized patient. And we are talking about TB, and we know that South Africa is one of the top incidence of TB in the world. And when you zoom into South Africa, at least 50% of people that are reported to have new TB or relapse TB will be having HIV or living also with HIV. And among those patients, 90% are on ARVs. So whenever we treat TB, we need to be careful about side effects so that we can immediately recognize them and activate a proper therapeutic measures. So let's see if this will be working. So which one of the following has not been described as an adverse effect of the standard 4 TB drugs that we use? No, it doesn't work because, okay, let's see. No, it doesn't work because it is not connected. So these are the side effects that we should be monitoring when we give patient TB drugs. And today we'll be focusing on dermatologic effects. And I'm skipping this because it doesn't connect to internet. So, and whenever we go into dermatological adverse reaction, we need to remember that gender, HIV status itself, that's why it was important, we were reminded that at least 50% of the patients that are on TB treatment or will be started on TB treatment will also be living with HIV. And the risk of HIV is shared for both dermatological adverse reaction and even DILI. Female gender share between DILI and cutaneous manifestation So this is just also a reminder that whenever we see DILI, we should be thinking of the possibility of cutaneous adverse reaction, or whenever we see cutaneous adverse reaction, we should not forget to look for DILI in those patients. So we all know that whenever you compare or you count the number of patients that are at risk of cutaneous adverse reaction, HIV significantly increase the risk of these complications. So the slide is not working. And the incidence, as you see there, can be as low as 5, but as high as 23. Not that uncommon, or almost in the same range with the risk for DILI. And we are all very knowledgeable about DILI, and we tend to forget the skin reaction. So this is just referring to findings in Korea, for example. As you can see, skin side effects were the second most common, and not far from home in Ghana, for example, skin is also there, and there were even more skin reaction than hepatotoxic reaction. So it is something that we need absolutely to master. So, and contrary to DILI, all drugs, rifampicin, INH, pyrazinamide, and ethambutol that is usually excluded from DILI can cause cutaneous adverse event. And this will be having implication whenever you are using a bridging regimen or a recovery regimen. You cannot afford to put ethambutol part of it. While in DILI, we use ethambutol as part of the bridging arrangement. As you can see there, all of them can cause. Yes, pyrazinamide in that study was causing more than other, and in this study, ethambutol was causing more side effects than the other one. So any single drug among the 4 can cause side effects. We need to be mindful of that. It does kill. We should be discussing with our patient all the time. Whenever we start a treatment and every time they come back to us, we need to discuss these side effects so that we can mitigate the complications. So patients should be educated about, in this context, about the red flag. Patients should be questioned directly. We should not only be waiting for the patient to tell us. The patient should know that they should immediately, we should empower them to report to us that they have side effects, so that, and we should be open to listening to them so that whenever they report, we take the correct action. So we need to empower them and not be dismissive. And these are the red flags that every single patient that is prescribed TB treatment should be educated on, so that whenever they go home, they should be told that if they have systemic symptom, fever, mucus involvement, blistering, edema of the lips or eyes, wheezing, or airways compromised, they should discontinue the treatment and report back. So those are the red flags that need to be told to the patient. And when the patient comes to us and they report these as red flag, we should, as provider, be mindful that it should be a prompt for us to stop the treatment. But again, it is not easy to recognize skin lesions, especially in the hyperpigmented, in pigmented skin. So, and just trying to see here, it was supposed to be part of the Slido. This maculopapular or mobiliform eruption. So let's be mindful of the fact that we might be struggling to recognize these lesions because they are not in textbooks most of the time, or even when you go on Google and try to search for pictures that gives you some of these lesions that are described for TB adverse reaction, you might not get them easily. So this is just a study that was published recently too, that reminds us how pictures of lesion in pigmented skins are very, very difficult to find. So we have around 40 different type or pattern of lesions that are there in the context of adverse reaction. So we have maculopapular or mobiliform rash that can be caused by any of the 4 drugs that we've spoken about. And as you can see there, it can be difficult at the beginning to differentiate between benign maculopapular lesions with early serious cutaneous adverse reaction. So whenever you see morbilliform rash, you need to probe further. If they say they have symptoms, then you need to recognize that it might still be early serious manifestation, and you should be, if you continue the treatment, you should be warning your patient about the possibility that it might become more, or if the patient doesn't come back, they might get Steven Johnson or TEN. So these are just some of the pictures for us to keep in mind, because the more we see them, the more it will be easy for us to remember. So this is just some of the pictures of morbilliform rashes when a patient is on TB treatment. Beside the morbilliform rashes, we need to remember that patients that are on TB treatment might have urticaria caused by most commonly isoniazid, but any of the 4 drugs can cause them. They can occur with or without fever. But remember that once there is a fever, then you need to be mindful of the fact that it might be serious and your patient should ideally stop treatment. These are the eaves that we see there. They can be extensive and coalesce. But patients can also experience what is called flushing. That will be a little bit difficult to see from if somebody has a very dark skin, but it does happen if your patient reports to you that they become more red after taking treatment within 2 to 3 hours. It might be a side effect of rifampicin or pyrazinamide. And when it is caused by INH, it will tend to come 2 to 3 hours after consuming like biltong or amas fermented food. The cure meat is biltong. Fermented food can be amas, so it will come and be triggered with those food or drinks. So this is just an illustration of flushing in a patient that was on TB treatment. But patient can also have photosensitivity, particularly if they are on pyrazinamide. So those are the things that we need to remember. They can also have lichenoid reaction, most notably caused by ethambutol and INH. And maybe some of you saw patient, and the lichenoid reaction can also be photosensitive. So those are both photosensitive and lichenoid at the same time. As you can see, if they are not photosensitive, that is where and how they do present. This is also lichenoid. If you see that on a patient, don't only think that it is caused by HIV, it might just be a reaction to one of the TB drugs, and in particular INH or ethambutol, but any of them. Ethambutol or INH should be on top of your mind as a cause of this type of lesions. This is, again, when you see them in on somebody with a black or darkened skin. That is how extensive it can become when the patient continue to use treatment and nothing is done for those particular patient. That is how bad it can be. This is when the patient was on treatment. This is after the patient completed the treatment. So, but most of those that we've discussed, except for anaphylaxis, will not really put your patient at risk of death. But these ones that are coming, the serious one that will happen to be systemic, are considered to be severe. And under severe one, we need to remember stress. Some people call it drug-induced hypersensitivity syndrome, DIHS. It is most commonly caused by rifampicin, INH, and ethambutol. It is rare, but it can potentially be life-threatening. So we need to be mindful of that. This is how DRESS can present. And this is in pigmented skin. This is also part of DRESS. It is not only about rash, as we were discussing. Remember, in the red flag, we say swollen face or edema of the face or the lips you need to stop the treatment. It is because it might be a manifestation of DRESS. So, and say systemic, not only by symptoms, but also by organs that will be involved. The liver, the kidneys, and the lungs might be involved. And the liver play a central role, not only in the disease, but also as a main cause of death in patients that have DRESS. So as you can see, a patient that has DRESS on TB treatment, almost 90% of them will have rash, more than 90%. They will have that is what they say, maculopapular drug eruption. That's why it was a reminder that when you see them, don't only take them as benign. There might be early manifestation of DRESS. Partial edema is significant. The patient that we manage, she gave me one of her pictures at the beginning. She had her face that was very swollen. So at time, mucus might be involved. The patient that we manage had also mucus urogenital that were involved. She had temperature, she didn't have lymph node, and unfortunately for her, she didn't, when we took blood, there was no eosinophilia. So we'll discuss those things later. So these are the things that whenever we consider DRESS, in green, I put things that we can do and should be able to do. Full blood count and differential so that we can have the eosinophil count. Liver function, because we say liver involvement is very crucial or is important, impact DRESS. we can do, the kidneys can be involved. That's why urine and serum needed to be done. If ALTs gives you signs of hepatitis, then you can consider to do INR later on. So, and DRESS is not only diagnosing them by feeling, there are established criteria for diagnosis, and a lot of paper tend to use the Registrar 1. Those, again, as you examine your patient, those are the things that you need to look for if you wanna formally diagnose your patient. At the end of the examination, it should be less than 2 impossible, 2 to 3 it is possible, 4 to 5 it's probable, and equal or greater than 6. When you score your patient, it will be a definite DRESS. MD Calc as you can just enter all those data, but you need to remember that it does exist, so that not only you think about it, if you think about it, to go further down and pin it down by grading or by diagnosing it formally. So the second severe systemic reaction is SJS and TEN. And unfortunately, we don't have access to the slide to interact. This is just pictures to give you an idea of what SJS and TEN are. Again, the longer we take, it might get to that point. It can involve also the eyes. That is how extensive it can become. It does involve urogenital. We tend not to check our patient there, or whenever they will tell us because we didn't check, we just offer them a syndromic management, while in fact it is a manifestation of drug reaction that happen to be severe if missed. Our patient reported burning, vaginitis and burning micturition when she had a rash. Patient with Steven Johnson and or TEN will have urogenital involvement in up to 70%. So we should learn to not only look at the skin, but also look for the mucus. It is a spectrum. We all know that. Less than 10, it will be SJS alone. And more than 30%, it will be TEN. And in between, you will have the overlap between Steven Johnson and the TEN. It is all about how much it's detached, not how much is red. So that is the percentage is not about what is red, it is about what is detached, so that you can grade the severity of the. And the black sheep, literally, when it comes to Steven Johnson and the TEN in TB, it can be caused by every single drug, but rifampicin more than others. Just to keep that in mind whenever you rechallenge your patient. So as you can see in this study, rifampicin, and it has been published in many papers that rifampicin was the most common causative drug when it comes to Steven Johnson. So again, side by side, DRESS and Steven Johnson, as you can see, there is not only the skin and the type of the lesion that differentiate them, but there are also systemic manifestation and need for lab to make sure that you don't miss anything. So again, in life, things are not always black and white, and there are a lot of overlap. It's not only about asthma and COPD, it's not only about DKA and HHS, we need also to remember that there are patients that can have overlap DRESS and Steven Johnson. So it should not be DRESS or Steven Johnson, because you can have Steven Johnson and DRESS. So those are things that we just need to learn, because remember, if there is overlap, it means the liver is more likely to be involved. So the time of onset when it comes to these side effect, it is relatively shorter compared to when you compare with DILI. And within a minute when it comes to anaphylaxis, within 2 to 3 hours when it comes to flushing, Steven Johnson will tend to get there later, and than DRESS. It's a little bit earlier than Steven Johnson. And the lichenoid drug eruption also, it is variable, but most of the time it will start as early as the first month, the first week to the first month. This is, again, just to have an idea which side effect is more common. It will be maculopapular 1. This paper from South Africa did focus only on severe adverse reaction. That's why the contribution of Steven Johnson DRESS and Steven Johnson and TEN is higher than the lichenoid manifestation, which appear to be not serious there, or not severe. So, but in other papers, maculopapular drug eruption is the more type of side effect that is expected. Again, remember that it can lead to death. That is why we need to recognize them promptly and take the correct measure. And whenever patient need to be sent away, this patient should be sent away. One of the signature of HIV on this, not only it is common on adverse reaction, not only that they are common because of HIV, but the severe one tend to be also more common in HIV patient than in HIV negative. The other one are found the same in both population, but when we talk about mortality in South Africa, but these are the data from Cape Town, it was 9%, so which is relatively lower than what is expected when it comes to Steven Johnson. And we all know that whenever when you compare the 9% of mortality in South Africa, but let's be clear, this is Ruteskir in Cape Town compared to what is expected to happen in general. Generally in developed country, it is higher than 30%, as you can see. So, and the hypothesis was that the population that was affected here is relatively younger than the bulk of patients that get Steven Johnson and TEN in developed country. And so these are some of the most recent data of mortality of Steven Johnson in America over the past almost 15 years, and it was about 50,000 people that got Steven Johnson that were followed. So you see that it is almost flat, and as you can see, SJS alone, it is only 5%, but when it's combined, it gets to almost 15%, and the TEN is slightly higher than 15%. But even if you compare these number to the one in Cape Town, the Cape Town are still favorable compared to what is happening, what is still happening in the developed country. This is just to be mindful of the impact of age. Even there in America, when they check, the people that survive were relatively younger than people that died, and that is significant. Where the patients are treated, that's why I was saying those numbers are the numbers in Cape Town. Can we assume that they can be replicated everywhere in South Africa? I don't think so, because even by reading just this paper, for example, even in America, it will depend on where you are. It will depend on your social status. It will depend on which type of hospital you are in and how much money. So, and how much money it means, the more they spend, the higher the mortality is, because it was severe. So it has to be mindful. It is like when you get somebody that comes to you with a burn that is not Steven Johnson of 50%, most of the time they are not actively taken care of unless you are in private. So the higher or the more severe the lesions, the more money we'll spend, but the higher the mortality. I took this just to remind one another the impact of age and where the patient is taken care of. Whenever it comes to severity or to prognosis, we need to know not only we did the diagnose, but if you happen to have a patient in the ward, you need to run a score 10 so that you know the probability of mortality whenever you are taking care of that patient in the ward. This is there. It's just for us, I want to be reading this. It's just to remember, the higher the score, the higher the predicted mortality. And as you can see, if your patient score 4, it is already above 60%. And this is just another way of putting it. And it has been validated for South Africa also. And as you can see here, these are the data from Cape Town. Whenever it was equal or greater than 4 on day 1, because it needed to be repeated 3 to 4 days later, mortality was 75%. And if at day 3, your patient score 4 or more, mortality is almost 100%. So again, now we need to manage. We know which drugs cause which type of drug, and we know that every single drug, when it comes to TB, can lead to adverse reaction when it cutaneous one, and rifampicin, it might be the one that is most commonly involved in a severe one, systematic. So when it is there, we need to remember, one of the things that we need to remember is that anaphylaxis needs to be able to be taken care of. So we just go, all of us, we know, we go to the website there and we get what needs to be done for somebody that has anaphylaxis. Besides managing anaphylaxis, we need to know that some of the patients, we can just keep them on treatment, put through with the treatment, provided that we manage symptomatically. So those patients will be flashing. You don't need to stop the treatment. Like drug reaction, they say you don't stop the treatment. You can continue the treatment, but also manage them with the dermatologist up until they completed the treatment, because once they will have completed the treatment, it will go back, but with scarring. And maculopapular rash, you carry on. Photosensitivity, you carry on. So again, just a reminder, don't miss early Steven Johnson or DRESS with maculopapular rash. Yes, if you exclude, you can carry on with the treatment, but in doubt, stop the treatment so that you don't expose your patient to complication. So, and because any delay in picking up Stephen Johnson comes with higher mortality. So once it is diagnosed, it is serious. The first step is to stop the treatment. You stop the treatment and all drugs need to be stopped. Even if you don't know which one caused the problem, you need to stop the treatment. But we need also to be mindful of the fact that when we stop, and that not only your patient can get drug resistance or treatment failure, or if they are infectious, continue to transmit the treatment, or because the disease is still progressing, they can get dissemination in the body. Any interruption of the drugs comes also with the price of mortality, unfortunately. And any interruption in TB drugs, especially in the intensive phase, comes with higher rate of mortality. So recognizing this, picking early this complication will shorten the time of interruption, because it will most probably heal quicker because the lesions are not extensive. So how long do we stop? Up until the skin goes back to a well-documented baseline, and up until, so it will resolve completely. And the internal organ is not only the skin that must heal, but if there was hepatitis, the hepatitis must go away. If there was AKI must, or AKD, it should also be resolved, documented to have resolved for you to consider rechallenging. So these are just the time to recovery. I will want to be reading this. So you will see that the time to recovery vary. The time varies with the type of adverse event. So you can see, for example, that in Stephen Johnson and the TEN, it can go up to it can take up to 2 months for it to recover. So now that we've recognized, we've stopped the drugs, we've observed the patient for resolution of the skin lesions, and we've monitored that the internal organ also have gone back to the baseline, we can consider rechallenging the patient. This is one of the most recent paper from South Africa again. Rechallenge, I won't read the definition. So rechallenge basically means we assume that the drug caused the problem, you stop, the patient goes back to normal, you put it back to try to confirm literally that it was the drug that caused the problem. So, but in anaphylaxis, you should never attempt rechallenge. If your patient got anaphylaxis, you would never attempt rechallenge. In countries where they have a lot of resources, or where TB is not as bad as South Africa or India, for example, they don't rechallenge. They will just give different treatment. But in our setting, there might be benefit for us to try to rechallenge, because if it is, we identify the drugs, we will only exclude one drug and the patient can carry on with one of the standard treatment. But one of the prerequisites, contrary to DILI, on paper, even the South African paper, they will tell you this patient needed to be admitted. DILI will rechallenge as outpatient, serious, severe, systemic, cutaneous adverse reaction. It should be in hospital by somebody that have been reading and try to rechallenge this patient. So these are things that we need to remember. You don't rechallenge a patient as an outpatient. How confident you are that your patient had the TB? Is it worth the risk? Do you ever access or not to alternative? And if it does come again, can you recognize and discriminate between the drugs that you've started and or restarted and the drugs that were in the background or the new drug? So back to normal for us to rechallenge. It should be in hospital. We should all train because we know how to manage DD. We should be able to manage cutaneous adverse event. We should make sure that we go back and double check that the patient had the TB. And we need to give to bridge the therapy with 3 drugs that the patient never used before. Contrary to DILI, as soon as you stop the treatment, you can give a recovery regimen. In cutaneous adverse event, you wait for the resolution. It is in preparation for rechallenge that you bridge the treatment. So those are the things that we should not forget to. So, and it depends on which paper you read. Other people, the first paper in 2020 from Cape Town was 7 days at least, but the most current paper, the small booklet of side effect that has just been published this month, it talks about at least 2 weeks of bridge therapy. So then once, which regimen do you use? Which drug do you use? So it is, I'll go fast, Levo. The doses are there. I won't be reading them. Linezolid, Terizidone. In DILI, Terizidone was a substitute for linezolid. So we need to remember that. But in cutaneous, Terizidone, linezolid, and Levo comes as the first choice. And the other one will be used if there are contraindication or there are not availability of this first line bridge therapy. So the first line bridge therapy is Levo, Line, and Terizidone. So the other one will be alternative, as you can see there. Either you use them when the other top 3 are not available or there are contraindication to one of the top 3. So the dose, we go read about them. Then when we start, contrary to DILI, you start with the standard dose. In cutaneous, it is additive. It is sequential and additive. So you start with your dose and you go up and you go literally by 4 days before you get to another drug. This is based on the data, again, from South Africa, that if you rechallenge, if it is positive, it will tend to occur within 72 hours. So the 4 days is to afford you the time to pick up the bulk of the positive rechallenge. So why do we do sequential and additive? With the benefit is that you might be able to pick up what is the offending drug and just take the offending drug out, continue the other one, and it will improve your patient TB outcome. So literally, this is just your pathway to rechallenge. So everything normalizes, the skin goes back to normal, then only then you start to bridge, and you bridge for at least 7 days, but currently let's say 2 weeks. Then depending on these other parameters, you will rechallenge your patient with INH, rifampicin, pyrazinamide, or ethambutol. In the booklet, it is rifampicin first, INH later. So, and later on, in that period of time, what you do, you need to be looking for clinical and laboratory feature of recurrence. So you monitor your patient, and whenever there is pyrazinamide, for example, reaction, you need to stop it promptly, immediately. And other people will tell you, you might even give corticosteroid if your patient gets a positive rechallenge on pyrazinamide. And we spoke about the 4 days interval, and you only proceed if your patient doesn't have a positive rechallenge. Depending on which paper, this is the seminal paper was dropping a drug every 4 days. The current booklet tells you to drop the bridge after completion of rechallenge. So you would be keeping the patient on treatment as you rechallenge. The full bridge therapy will be kept. So let's be mindful. We know the sequence, but it's also, as we say, it is additive. The rule of thumb, you can keep this table if you want, but the rule of thumb is that the first day it is the quarter of the usual dose. The second day it is the half of the usual dose. The third day is the usual dose, and you carry on. That is just the easiest way. So if now you think of usual dose, then you need to be mindful of the body weight dosage of every drug. This gives you the usual dose, then you just do quarter, half, then full dose. So again, this is the document that I was referring to. The difference is that they start with rifampicin, and they drop the drugs at the end only, and they will also prefer not to rechallenge ethambutol. So those are just things that we need to be mindful of. And as we rechallenge, remember almost every other day, ALT, eosinophil creatinine need to be done on your patient, even more frequently if there are abnormalities. So how successful it is compared to DILI, for example, where we can have up to 90% success rate in rechallenge, meaning your patient goes back and tolerates the treatment. Unfortunately, when it comes to cutaneous side effect, as you can see there in severe one, this is again a paper from South Africa recently published, up to 70% of patients will have a positive rechallenge. It means that will limit the treatment. So even when you rechallenge, you don't just give and forget to monitor your patient, because they are very likely to. 3 out of 4 might get a positive rechallenge that might need your treatment to be limited. And this is almost 8 people will not react to one drug only. They will react to more than one drug. So it's even when we start, we say we go pick up the offending drug, but it might be offending drugs that you'll be picking up whenever you rechallenge your patient. So this again, as they were rechallenging, they got 3 reactions that met the criteria of life-threatening. So it is not a walk in the park. You need really to be dedicated and be very knowledgeable and do the right thing when you are monitoring this patient. As you can see there, when you rechallenge, it can be as early as 6 hours, less than 6 hours after swallowing your first dose. And by the next day, almost that was the median time to detect a reaction. So this is just the summary of that paper. So the rechallenge positive, meaning the patient fell or reacted again. And as you can see, down again, when you compare, is that there were more HIV positive than HIV negative that got the reaction. It's just another reminder that when you live with HIV, you are at risk of complication. So when you fail, if, for example, the culprit was rifampicin, again, go into the booklet. They will tell you which drug do you go for or which regimen you should go for if you decide just to drop the standard treatment. So our patient was switched to a second line because of the challenges of hospitalization, was sent to the DR hospital to assist. Unfortunately, as soon as she swallowed the second line therapy, she reacted again. So it is not a panacea. Changing the regimen basically is not a panacea. So, and as published there, a third of patients can develop skin reaction to the drugs that they never used before. So it was expected that it's not that they did something wrong, it was meant to happen. Fortunately, the patient was educated, and the following day, so the same day she reported, and the following day the treatment was stopped. So again, you can have multiple drug hypersensitivity, and there is a syndrome that is going that way. So it means you react to more than 2 drugs. So in this particular patient, it means she could have reacted to one of the drug in the first line and one of the drug, or more than one drug in the second line. So it does exist, and it is more common when you have DRESS. If you have a DRESS, your risk for multiple hypersensitivity is higher. And what next for that patient? So go back again there, stop everything, because at the end of the day, you just check. It was to say that the patient was diagnosed at the clinic using LAM. We don't have a proof of that LAM. And whenever we do a LAM, we should be documenting that I compare with which line, because it's not only that there should be a line, but that line should be as bold or the same tone as the tone should be the same as one of the line. So if the line is there, but it is lighter or fainter than any of the line, that LAM is negative and not positive. So I hope that we've learned something. And today was Funda Friday, but in Ward 5, we Funda every day. So this is just to introduce to you, for those that want to every day, they can join us on that channel. Thank you very much.
Thank you very much, Dr. Kayembe. Very important. And quite often skin reactions get managed badly because people just manage it like dilly. And I think it's very important just to also remind us that it's a completely different type of drug interaction. And thank you very much also for priming us on the very recently published new adverse drug event booklet that's just been printed by Mick. I have put it on the intern group to be sent round, and I've also put it on the Family Medicine group. So just look out for that. If you want to go and find it on the Medicine Information Center website, there are all the posters as well as booklets that's helpful for HIV care. I'd like to see if there are any questions. Please put your questions in the chat if you have questions for Dr. Kayembe and you're online. Are there any questions or comments from the floor here at Family Medicine? I think that was a very comprehensive presentation. Thank you very much. This recording will also go onto the Worcester Family Medicine Family Medicine Rural Health Department YouTube channel. And do look out also for Dr. Kayembe's Filter YouTube channel for some excellent presentations, and do try and link in when they are meeting. Thank you very much, everybody. And this will be our last presentation, obviously, for 2024. Hope you all have a lovely Christmas and New Year. And we will start again probably the year next year towards the end of January. Thank you very much, everybody.